Hello, coders. Good morning, good evening, good afternoon, all, depending upon where you're joining us from. First of all, please let me know. Someone let me know. How do I sound? Am I audible? Is my mic doing good? Okay, thank you, Miss Mills and Miss Catherine. Okay, Coda, so welcome back. That's what I would say. Welcome back to the CPT Guideline Mastery series or mastery sessions. So we had a small break before, and I hope you didn't miss us or our sessions too much. So in case if you missed, don't worry. We are back with brand new sessions of CPT Guideline Mastery, and today we will be diving into the breast surgery coding procedures where we will be reviewing the CPT guidelines and also we'll be doing a lot of practice scenario. So get ready with your CPT manuals. If you haven't taken them out yet, please go ahead and take your CPT manuals because we are going to do a lot of exercise today. All right. So let's begin by before that, let me see who all are here. Hi, Lucky. Welcome back. Let me welcome my team, Miss Mills, and I can see Miss Catherine is there in the chat as well. Okay, okay. Miss. I'm not sorry. I'm not able to pronounce the name. We have Deborah. We have Barrett. We have Nina. Okay. Hello, everyone. Welcome to the CPT Guideline Mastery session. So let me begin by reading out the copyright CPT copyright 2026 American Medical Association, all rights reserved. CPC is a registered trademark of AAPC. AAPC content found within this presentation is copyright of AAPC. Keyword concepts FTR Chun, AMCI FAB 7, AMCI ICD 10 Sleep Tab, and MCG are the trademark of AMCI. The credentials CPCC, RCC, OC, CPMA, CPB, CPPM, CPCO are owned by AAPC. AMCI do not own right to these credentials. The credentials CCA, CCS, CCSP, RHIA, RHIT are owned by AHIMA. AMCI do not own right to these credentials. So, as always, a gentle reminder, coders, please don't forget to fill out that survey form and let us know how you felt about the session which we're going to have today. Okay, so we usually have a good attendance, good number of students attending the live sessions, but we don't get much of the survey response. So please do make sure and please don't forget to put that survey or complete the survey link, survey yeah, survey post. Okay, I've posted that survey link in the chat by the way. Okay, so what are we going to review today? As I said previously, we will be reviewing a topic which is not much discussed from the integumentary section. Yes, I haven't seen much discussion going around the breast surgery coding. So we will be reviewing them. Initially, I thought that it will be a small session, but by the way it went, the building, the contents, I think that it will be a little bit more extended than the usual 1 hour session. All right, so be ready, coders. And the topics which we are going to discuss today falls under the integumentary system chapter, and the code series ranges from 19000 to 19499. And these are the goals for today's session. We'll be reviewing the breast biopsy codes and guidelines. We'll be reviewing percutaneous image guided placement of breast localization device codes, mastectomy procedures, and also we'll do some practice scenarios as well. Okay, so let's not waste much time. Let's go straight into today's topic. And we're going to start the session by looking into the topic breast biopsy procedure. So when we hear about or when we hear the word biopsy, it can sound a little intimidating, right? But the basic idea is actually very simple. Breast biopsy is done when provider finds something in the breast that looks suspicious. A lump, it can be a lump, it can be a mass, or some abnormal area seen during the exam, like it can be seen during your mammography results, ultrasound results, or even MRI results. So the goal is actually to take a sample of these tissues and send it to the pathologist. Now, for the coding, first thing I want you to ask yourself is, how did the provider get the tissue sample? Yes, that's the first thing you should ask yourself when you're coding for a breast biopsy procedure. Because there are actually two main ways to do a breast biopsy procedure. First is a percutaneous method, where the provider will use a needle through the skin to collect the tissue, that is percutaneous biopsy. And once the tissue is obtained, the surgeon might leave a metallic or some clip, metallic or marker clip, so that he can come back and do a more invasive procedure if needed. All right. Second one is open biopsy. Now, if the provider actually makes a surgical incision to reach the abnormal area, that is an open biopsy procedure. And open biopsy can be done like as an incisional biopsy or excisional biopsy. So, incisional biopsy means that only the part of suspicious area is removed, while the excisional biopsy means entire lesion or entire abnormal area will be removed. So that's the difference between these two procedure or these two approaches. All right. So first, let's take a look at the percutaneous breast biopsy coding. So once you identify that you're looking or you're going to code for a percutaneous biopsy, first question you should ask yourself is that, was imaging guidance used or not? All right. So if the provider performs a needle core biopsy without imaging, that's when we look at CPT code 19100. So this is pretty much straightforward. 19100 is coding for biopsy of the breast, percutaneous needle using not using image guidance. And if the image guidance were used, we move away from 19100 into another series of codes. They are 19081 through 19086. Okay, so pretty simple so far, right? So now that we know image guidance was used, our next step is to find out what type of image guidance was used. So let's go ahead and let's take a closer look at the codes 19081 through 19086 and see how we choose the correct code. Okay, all right. So 19081 through 19086 is used for biopsy of breast with the placement of breast localization device when performed with image guidance. And these group of codes, these sets of codes are actually can be grouped into three pairs. So you can see this now, okay, based on the type of image guidance used. So if we are performing a breast biopsy with placement of breast localization device using a stereotatic guidance, you would code 19081 and 19082. Okay, and 19081 is to be reported for the first lesion. And add-on code 19082 is used for the each additional lesion. So there were two lesion biopsied using stereotatic guidance. The first lesion code would be 19081 and the additional lesion code would be 19082. All right. So similarly, we have codes when uh, ultrasound guidance is used, that is 19083 and add-on code 19084. And finally, we have 19085 and 19086 to be used when we use MRI guidance. So it's simple. These are classified easily based on the type of the guidance used. Okay, so make sure you chun your manual because here at AMCI we always say chun is life, and chun can really help you to save time during your board exams. Okay, on this slide, let's walk through guidelines for coding multiple breast biopsy using three quick scenarios. Okay, in scenario one, here we have two lesions in the left breast. Over here, we have two lesions in the left breast, and both are biopsied using stereotactic guidance. So keep in mind, both lesions are biopsied using the same guidance, that is stereotactic guidance. So in such scenarios, for the first lesion, you use 19081, and for the second lesion, you use in the same breast, you use the same imaging guidance code, that is the add-on code 19082. All right, 19081 is for a breast biopsy using stereotactic guidance. Since it's the same imaging modality that has been used for the second lesion, you simply use the add-on code 19082. Okay, that was your first scenario. Now, let's move on to the second scenario. That is when we have one lesion in the left breast and other lesion in the right breast. And again here, both of the lesions are biopsied using same image guidance, that is ultrasound guidance. Again, the guideline is the same. If same modality is used, you will use the first primary code for ultrasound guidance, which is 19083, and add-on code 19084. So since it is in two different, or one is in right breast and one is in left breast, we won't use a different primary code. We use just first parent code, that is 19083, and its add-on code 19084. Okay, now comes the third scenario, scenario number C. And in this scenario, one lesion is biopsied using ultrasound guidance, while another lesion is biopsied using MRI. Okay, now coders, remember, here we are using two different imaging modalities. Okay, one lesion was biopsied using ultrasound guidance, the other was biopsied using MRI guidance. So because two different imaging modalities are used, we do not continue with the add-on codes from the first modality. Instead, we report primary code for each imaging modality. Okay, so 19083 will be used for the first lesion, that is for ultrasound guided biopsy, and 19085 will be used for the image for the MRI guided biopsy. So it's simple. The rule of thumb is simple here. Same imaging modality, you will use primary code plus add-on code for the additional lesions. Different imaging modality, start a new primary code, and always make sure laterality is clearly documented. Okay, all right. So I hope this guideline is clear. Type in the chat if it's clear for you all. Okay, please let us know. All right. Next, we have CPT code 19101. That is for open incisional biopsy procedures. As I said in the beginning, open biopsy procedure can be of two types. One is incisional and one is excisional. So 19101 is for open incisional biopsy. And moving on to the next slide. Here we are going to look at open excision of biopsy of the breast lesion when radiologic marker was placed before the surgery. So this is a two-step process. First, before the surgery, the radiologist uses image guidance to place a localization device. For example, a wire, a clip, or a metallic pellet, or any other markers to identify exact location of the breast lesion. Now, That preoperative localization is reported with the code 19281 through 19288 code family. And we are going to review these code family in the upcoming slide. Okay. So they are just for placement of localization device. All right. Then comes the second step. In the second step, surgeon performs an open excision and removes the breast lesion that was identified by that preoperatively placed marker. So first lesion you will report 19125, and if there is any additional lesion identified, then we report add-on code 19126. All right. And in these scenarios, you can also code for those pre-operative placement of the image guided placement of the localization device. Okay. Now let's look at few specialized breast excision procedures involving nipple and lactiferous ducts. These are pretty much straightforward. You have 19110 through 1912. So these are straightforward codes. So I'm not going to go in detail discussing about them. You can easily read and understand these codes and their definitions. So let's move on because we have a lot to discuss today. Let's move on to the next slide. All right. So when the same breast procedures is performed on both right and left breast, we need to determine whether the particular CPT allows us to report all the services as bilateral. That is using a 50 modifier, because sometimes CPT codes doesn't allow us to use a 50 modifier. So the codes 19100, 19101, 19105, and 19110, 19112, 19112 allows the usage of 50 modifier, while the codes 19081 through 19086, those are your breast biopsy codes. They don't allow you to use the 50 modifier. And I hope you know the reason why, because if it's performed in the bilateral or in the second and the other laterality, you should use the add-on code, or you should use another image modality CPT code, right? That's what we just learned in the previous slide. So make sure you churn these guidelines in your manual. Okay. So previously we talked about placing clip or marker as a part of image guided breast biopsy, right? In that case, the marker placement is already included in those biopsy code, which is 19081 through 19086. So now we are going into another section where the provider is only placing the localization device and no image guided biopsy is performed at that time. Okay, previous section we learned that biopsy is performed along with a marker or a breast localization device is placed. Here, it's just the image guided placement of breast localization device that is performed. No biopsy will be done. So sometimes this is done because sometimes breast abnormality is very small or cannot be easily felt during the surgery. And in that situation, the provider may place a localization device such as wire, needle, clip to know the exact location of the abnormal area. So you can imagine like placing a pin on the map, and this will help the surgeon to know exactly where the suspicious area is located. Right now, if the provider is placing this localization device without performing image guided biopsy at the same time, that's when we look into the code series 19281 through 19288, and we choose these codes depending upon two things. One, what type of image guidance is used, and how many lesions were localized. Okay, so let's break this code family down. Similar to the biopsy codes, they are also classified based on the guidance used. You have 19281 and 19282. That is when mammographic guidance is used. And 19283 and 19284 is used when stereotatic guidance is used for the placement of the localization device. And we have 19285 and 19286 for ultrasound guidance, and 19287 and 19288 for MRI guidance. So the first code in each pair represent the first lesion, and the second code is the add-on code for each additional lesion. Pretty much same, right? Yes. Okay, I can see a few new members have came. Welcome, welcome to the session. Okay, so moving on to the next slide. All right, now let's bring everything together with a simple decision pathway. So, first question you should ask is that does the procedure also include image guided biopsy or not? So, if it does not include the image guided biopsy, then you should look at the CPT codes ranging from 19281 through 19288. If it use image guided biopsy, then you should choose codes from 19081 through 19086. As simple as that. All right. Now, the guidelines to be used when multiple localization device placed is similar to that the biopsy. Okay, so I will explain it with the similar example. We have two scenarios, scenario one and scenario two. And the main thing we need to identify is whether the provider is using same imaging modality or different imaging modality. If same imaging modality is used, one primary code for the first lesion, then appropriate add-on code for additional lesion should be used. And if different modality is used, new primary code for each imaging modality should be used. All right, it's similar to the biopsy scenario or biopsy guideline. So we'll do some exercise. I believe it's next is some exercise. Okay, before that, I have one more topic to cover here. The CPT code 19284. All right, this code should be used when patient has a partial mastectomy, which means partial mastectomy means surgeon removes the breast tumor or a part of the breast tumor, and after that after the tumor is removed, there is an empty space. So you can visualize what's happening there. After removal of the tumor, there is an empty space or cavity left behind, right? So surgeon will prepare that cavity and place a special radiation applicator into the radiation, so that radiation can be given directly to that area during the same surgery. So just after removal of the breast tumor, the cavity is repaired and a radiation applicator is placed, which will provide or which will emit radiation into the surrounding areas. And this is done exactly during the same surgery or during the same session. And that is when you use CPT code 19294. And this is an add-on code. And yes, this is an add-on code. So it's not reported. It's reported along with the mastectomy or partial mastectomy CPT code like 19301 or 19302. And next we have CPT code 19296 and 19297. Now these are after loading catheter codes. Here a special catheter is placed into the breast, so radiation treatment can be delivered later. So main question while coding the scenario is that when was the catheter placed? If the catheter is placed on a different date from the date of partial mastectomy, we use CPT code 19296 over here, 19296, when the catheter placement is on a different date. While if the catheter is placed on the same date or during the same surgery as of the partial mastectomy, we use CPT code 19297. And another important guideline to keep in mind is that as the description say, they include the image guidance as well, right? And then we have one more CPT 19298 that is used for placement of multiple brachytherapy catheter into the breast, either at the time or after the partial mastectomy. Okay, so let's do a small hand poll exercise to recollect what all we have learned so far. Okay, so you can type the answers in the chat coders, and participation is encouraged. Please go ahead. If even if the answer is wrong, that's fine. I want everyone to participate in this small exercise. And here is your question. How should these two placements be reported? Option A, one primary code for first lesion and an add-on code for the second lesion. Option B, separate primary codes for each distinct imaging modality used. Option C, single primary code with bilateral modifier. Option D, only mammography guided placement is reportable. A physician places percutaneous localization device in a lesion in the left breast under ultrasound guidance and then places a second device in a separate lesion in the same breast under mammographic guidance. How should these two placements be reported? Recorders, type your best answers in the chat. Okay, I'll give you around 30 seconds. Place your answers in the chat based on the guidelines we have reviewed so far. So it's simple. A percutaneous localization device is placed at left breast or into the left breast under ultrasound guidance and then place a second device into separate lesion. So this is basically a percutaneous localization device placement. And if you remember the guideline, I will give you a small hint. You should focus on the image guidance used rather than the laterality. You should document the laterality, by the way, but choosing the CPT code depends upon the guidance used. I can see some answers are already in the chat. Go ahead, coders. I will give you 10 more seconds. Please, your best answers in the chat. Because only when we participate in sessions like this, we will remember what went wrong, or even if you go if the answer is wrong, you will remember why it was wrong. Okay, so always participates in activities like this. All right. Okay, so the answer is option B. Separate primary codes for each distinct imaging modalities used. Because, as I said, the localization device was placed in the lesion in the left breast, and the guidance uses ultrasound, and then places a second device in a separate lesion and the same breast using mammographic guidance. So if two different guidance are used, you should use two different primary code. One primary code would be, or the first primary code would be for the ultrasound guidance, and the second primary code would be for the mammographic guidance. Okay, so I hope that was a teachable moment. That was an aha moment. Let's go for another one. Okay, which guideline applies to reporting the imaging guidance for this procedure? Option A, imaging guidance is included in the placement service and cannot be billed separately. Imaging guidance must be reported separately using standard ultrasound and CT code. Imaging guidance is only reported if the placement occurs on the separate date from the mastectomy. D, image guidance is not allowed during the procedure. A patient undergoes placement of radiation therapy after loading expandable catheters into the breast for the interstitial radio element application. Which guideline applies to the reporting imaging guidance procedure or imaging guidance for this procedure? Okay, this was the last CPT codes which we reviewed before this exercise. So the tip is that is imaging guidance included in this placement code or not? Okay, type your answers in the chat, Cora. So I can help you with this. Okay, I will show you the CPT codes. Okay, I know I'm helping a lot. Look at the codes. All right, I will go back to these are the codes. I will go back to the question. Okay, this is the question, and you can type your answers in the chat. Okay, I can see the answers coming. Okay, I will give you 10 more seconds, Kodas. Go ahead, go ahead. Give your best answers. Yes. Yes, option A is the right answer. Imaging guidance is included in the placement and cannot be built separately. That's what you can see in the code language as well, right? You can see in the code language includes image guidance. So that means it's included and you should not build them separately. All right, third one. According to the clinical guidelines, can both localization placement and open excision reported, not clinical guidelines, let it be coding guidelines. According to the coding guidelines, can both localization placement and open excision reported? Option A, no. Localization placement is considered bundled into open surgical excision. Yes, both percutaneous placement and open excision may be reported. Option C, no. Only open excision can be reported, but with a specific modifier or a special modifier. Option D, yes, but only if they are performed in different facilities. A surgeon schedules an open excision of the breast lesion before the surgery, and radiologist performs percutaneous image guided placement of the localization device to mark the target area. Recorders, please your answers in the chat. Okay, what's my tip for this scenario? Okay, the keyword. I will give you the keyword just before the surgery. Okay, so it's pre-operatively, not intraoperatively. Okay, just give me 10 seconds, coders, because we have a few more slides to cover. Go ahead, go ahead. Give your best answers. Okay, so the answer is actually B. Yes, both percutaneous placement and open excision may be reported because of the guideline if it is performed before pre, uh, or before the operation or before the surgery. You can report both, but if it's done during the surgery, you cannot report. So let me try to grab that guidelines for you all. Let me see. Okay, it's over here. Okay, intraoperative clip placement is not separately reported, but if it is performed preoperatively, you can see open excision with preoperative radiological marker. It's done before the operation or before that surgery. It's done in two steps. Remember what I said? Done in two steps. First, you will place the image guidance clip, and next you will perform the excision, open excision. So if it's done before the surgery, you can report both. All right. So again, I believe you have learned something from that exercise. And let's move on. Let's move on to the next one. Okay, give me a second, Codus. I think I lost my on clicks. I will just refresh the slide. Hang in there. Okay, it's loading. And back. And the code is okay. We are back. So let me share my screen. All right. You're welcome. You are always welcome. So next, we are going to look at the mastectomy procedures. And mastectomy, as you can see, is a surgical procedure where part or all the breast tissues are removed, and it is usually done to treat breast cancer or to reduce the risk factor. So the type of mastectomy actually it depends upon how much breast tissues are removed. So there are three types of mastectomy, or it can be four types. First one is partial mastectomy. So here only important thing to note is that here only a tumor or a portion of the surrounding breast tissue is removed. And then we have simple or total mastectomy where the entire breast will be removed. And next we have a modified radical mastectomy where the breast is removed along with the axillary lymph nodes. And fourth one is that the radical mastectomy. So for the radical mastectomy procedures, it removes the breast, the lymph nodes, and it also removes the chest wall muscles. And this is actually the radical mastectomy is less performed these days. Okay, so these are the four types of mastectomy procedures, and depending upon the breast tissues or the amount of tissue that is removed. Okay, so when we look into the CPT code for the mastectomy procedures, remember that most mastectomy procedures are performed for treatment or prevention of the breast cancer. Okay, and only exception for the codes for the mastectomy is that 19300, and this is the only exception code which is specifically used for gynecomastia. So when you see a documentation stating that mastectomy was performed for gynecomastia, you will use 19300. All right. And then let's move on to the cancer related mastectomy procedure 19301 and 19302. So, as I said, 19301 is for partial mastectomy, 19302 is for a partial mastectomy or a mastectomy with axillary lymph node uh, dissection. It's for a complete axillary lymph node dissection. All right. So that's the difference between these two CPT codes. And next we have 19303. So yes. So this is coding for a mastectomy simple or complete, meaning the breast tissue is removed but no axillary lymph nodes or pectoral muscles are included. So you can simply follow the code language here to have a better understanding of what or how much tissues are removed. So simple complete means just the complete breast is removed. Okay. And then we have 19305 which goes further. So here breast tissue, axillary lymph nodes, and both pectoral muscles are removed. And then we have 19306. So this is basically 19305 plus internal mammary lymph nodes. So all structures in 19305 is also removed along with axillary, sorry, internal mammary lymph nodes. That is an additional structure that will be removed. And finally, 19307, which is modified radical mastectomy. And here a lot of structures are removed: breast tissue, axillary lymph nodes, pectoralis minor may or may not be removed. But important point is that pectoralis major is preserved. Okay, so you can refer to this box just for guidance on see what all structures are removed. So remember, mastectomy procedure, keep in mind what all structures or how much of the breast tissue is removed. That will help you to select the correct CPT code. And these are other few breast procedure that you will see in this section. Again, these are self-explanatory, so it's simple. You can just follow the code language to understand them. And let's move on to the next section, that is repair and reconstruction. Now, when we talk about breast reconstruction, the goal is basically to restore the breast shape or the shape and the symmetry of the breast. Okay, and this may be needed after the breast surgery, after the loss of breast tissue, or sometimes because of congenital abnormalities. So, important thing to remember is that reconstruction is not always just done in one procedure or at one go. Sometimes patient may need more than one technique, or in some cases more than one planned surgery. Now let's look at three common procedures that you will see in this section. First, you can see the CPT code 19316, which is a mastopexy procedure. Mastopexy simply means the breast lift procedure. So that's a keyword. Can be it's a breast lift procedure. Second is 19318, which is breast reduction procedure. So here the goal is to reduce the size of the breast by removing excess tissue, fat, or skin. All right. And then we have 19325, which is for breast augmentation with implant. And this is when breast implant is placed to increase or restore the breast volume. So the code language is clear: breast augmentation with an implant. Okay, so let's move on to implant based reconstruction. So here, as you can see, basically when an implant such as saline or silicone implant is used to restore the shape and volume of the breast after a mastectomy procedure. So for coding, easiest way to remember this procedure is just ask one question: when was the implant placed? Because if the implant is placed during the same surgery as the mastectomy, that is immediate reconstruction. And we report CPT code 19340. Okay, so when a breast reconstruction is performed immediately after mastectomy, you will report 19340. Now, if the patient comes back later and the implant is placed on a different date, that is considered as a delayed reconstruction, and that procedure will be reported using CPT code 19342. So 19342 means that it's a delayed procedure, and it can be also used when an existing breast implant is replaced with a new implant in a reconstructed breast. Okay. Next, what are we having next? Let's look. Okay. All right. Next, we are going to talk about the tissue expander in breast reconstruction procedure. So sometimes after the mastectomy, surgeon cannot place the breast implant or the permanent breast implant right away. This is because there may not be enough skin or space to safely accommodate the implant. So what they do, they first place this thing called tissue expander. Think of tissue expander as a temporary inflatable implant whose job is to slowly create enough space for the permanent implant. So tissue expander is surgically placed underneath the skin and chest muscles. Then over next several weeks, provider will gradually add a saline to the expander during the office visit, and little by little the expander and the surrounding tissues stretches the surrounding tissues and create an opportunity for the size pocket and creates an appropriately sized pocket for the future permanent implant. So tissues expander is just to create that space for the implant to be placed or implant to come in. So for the placement of the tissue expander, we use CPT code 19357, and remember, the subsequent saline expansions are included in this code 19357. And once enough space has been created, patient can come back for the next stage. So the surgeon will remove the expander, tissue expander, and place a permanent breast implant, and that is reported using CPT code 11970. Okay, when a permanent implant is placed by removing the expander, you use 11970. And the removal, uh, and what if the surgeon removes the tissue expander but not put any another expander or permanent implant back in? That's when you use CPT code 11971. Okay, so we are almost getting to the end. Next is for or regarding autologous breast reconstruction. So autologous reconstruction means that we are using patient's own tissue to help rebuild the breast. One example is latissimus or latissimus dorsi flap, and it is reported using CPT code 19361. So what actually happens here is that you can see the image as well. If you're a visual person, the surgeon will take the tissue from patient's back and mainly the latissimus dorsi muscle, and usually along with some overlying skin and fat, it is moved or a flap is made, and this flap is not completely disconnected from the body, and its blood supply will remain attached through the vascular pedicle. So the surgeon then turns the tunnel tissue under the skin through the axilla or armpit and brings it around the front of the chest, and the tissue is shaped to help recreate the new breast mound. So you can see the muscles and the skin has been taken from here. There will be still a connection, a vascular pedicle connection, and that will be a flap will be created, and it is used to cover the place which require reconstruction. Okay, so that's a breast reconstruction with latissimus dorsi flap. All right, now let's look into CPT code 19364, which describe free flap breast reconstruction. So, what's a free flap breast reconstruction? Here, it's similar to what we saw in previous CPT code. Here, the skin and fat and sometimes muscle is taken from another part of the body, like abdomen or buttock. But unlike the previous pediculated or pedicelled flap, the tissue is completely detached. So here there will be no pedicle or no connection. The tissue will be completely detached, then transferred to the chest. And what happens here is that surgeon reconnects the blood vessel using some microsurgery. He will perform microsurgery and then he will connect the blood vessels and shapes the tissue into the breast mount. All right, so this is the image you can see from the abdomen or buttock skin muscles and the tissues are taken. It is placed into the breast area, and under using a microsurgery, the blood vessels are connected and the reconstruction is performed. Okay, so the common example include TRAM, DIEP, SIEA, GAP flap. These are your keywords. You can see over here 19364. These are your key words. And next we have, let's look into the tram flap variation. So there are three tram flap variation. So tram flap actually uses tissue from the lower abdomen, including skin, fat, and part of rectus abdominis muscle to reconstruct the breast. So three main variations are there. First one is 19367, that is single pedicle tram flap. So here one rectus muscle is used and flap stays connected to its original blood supply. Okay, the tram will be connected to the flap will be connected to the original blood supply. And in 19368, single pedicle flap with supercharging. So here also basically it's the same single pedicle flap, but the surgeon adds extra microsurgical vessels to connection to improve the blood flow. So you will have one pedicle plus the surgeon will also do some microsurgery in order to add some more blood vessels. Okay, that is known as supercharging. That will increase the blood flow to that flap. And in 19369, that is bipedicle trap, here both rectus muscles are used to provide blood supply for reconstruction of a single breast. Okay, so that is, so there will be two pedicle connection. So these are some of the reconstruction methods. All right, so let's look into the final few codes. We have separate CPT codes for the removal of the implant, that is 19328, and 19328 is for if the implant is used when the implant is intact and simply being removed. And if the implant is ruptured, we use code 19330. So here the code selection depend on whether the implant is ruptured or implant is intact. All right. Now let's look into the capsule management codes. So there are two CPT codes for capsule management. Now you might be thinking what a capsule is. So over the time, the scar tissues forms around the implant. So after the implant, there will be some scar tissues formed just around the implant over a period of time. And this scar tissue is actually known as capsule. So CPT code 19370 is used when the surgeon is revising or adjusting the capsule, so and CPT code 19371 is used when entire capsule along with the intracapsular contents are removed. Okay, you can see including the removal of all intracapsular content. The first one is just for revision. The other one is for removal. Okay. All right, and finally we have few more breast reconstruction codes. 19350, which is used for nipple or areolar reconstruction. We have 19355, that is used for correction of inverted nipples. And we have 19396, which is used for preparation of moldage for custom breast implant. And finally, we have 19380 for revision of reconstructed breast. So these are the breast reconstruction procedure CPT codes. And I know we had a lot of codes here, right? So you can classify them simply like this. Just to give you an overview of what all we have covered, we have excision codes, we have preparation, we have preparation, removal, we have preparation and removal codes, we have reconstruction codes, and we have refinement codes as well. So if you churn your manual, as I said previously, it is going to be easy. Churn your manual, notate your guidelines, and you will be fine. So let's do some exercise before we close the session. So here we go, coders. Here's your first scenario, and you have answers over here. Type your best answer in the chat. Of the following answers, which code best describe the procedure? You have option A, 1919303, 50 modifier, 19304, 340 with a 50 modifier, 19303, 19342 with 50 modifiers, 19305, 19340 with 50 modifiers, 19301, 19340 with 50 modifiers. A patient at high risk for breast cancer elects bilateral prophylactic simple mastectomies. During the same operative session, surgeon places bilateral saline breast implant immediately following removal of breast tissue. No axillary work is performed. What is the correct code selection? Okay, coders, place your answers in the chat. And you have 2.5 minutes. You have 2.5 minutes to place the answers. Go ahead. Okay, that is time. And let's see. Let's see. I can see the answers in the chat. If there are someone still working on, go ahead, please the answers. And here, what do we have? We have a patient with simple mastectomy. So that's one of your keywords. And during the same operative session, breast implants were immediately placed, right? Just following the removal of the breast tissue. So first keyword is simple mastectomy, and 19305 is coding for mastectomy radical. If you remember, I said, what is this radical mastectomy? It involves removal a lot of tissue, right? It's not a simple mastectomy. While in our procedure, it was, or in our question, it was clearly documented that this was a simple mastectomy procedure. So option 19305 has to go. 19301 is coding for a partial mastectomy. Again, this is not a partial mastectomy. This is a simple complete mastectomy. So option D is also incorrect. Between option A and B, both are coding for 19303. That looks like a good code. 19303 is for mastectomy simple complete. So that's a great answer. Only difference is in the secondary codes. So option A coding for 19340 and option B coding for 19342. 19342 is for insertion or replacement of breast implant on separate day from the mastectomy, while 19340 is for insertion of the breast implant on the same day as or same day of mastectomy procedure. Or in other words, it's for immediate placement of the breast implant. And from our scenario, it was clear that the breast implants were placed immediately following the removal of the breast tissue. And that was done on the same day as well, right? So the correct answer definitely has to be option A, 19303, one with the and 19340, both with the 50 modifier. So great work. I can see great work, Linda. Great work, Christina. Great work, Nazarene. And great work, Deborah. So good job. Let's move on to the next one. Here we go. Of the following answers, which code best describe the procedure? You have option A 19367, option B 19361, option C 19364, option D 19369. Following mastectomy for breast cancer, a plastic surgeon performs microsurgical breast reconstruction using deep inferior epigastric perforator, which is DIEP flap, including harvest microvascular anastomosis of one artery and two veins, flap inset, and donor closure site. Of the following answers, which best describe the procedure? Your 2.5 minutes has begins now. Okay. Okay, so that's time, and let's look into the let's take a look into the scenario. Here we have a patient who underwent a microsurgical breast reconstruction, and keyword in the scenario is GIEP flap. So after this flap was obtained, there was a microvascular anastomosis of one artery and two veins done. Okay, so CPT code 19369 is coding for a breast reconstruction procedure with bipedical transverse rectus abdominis myocutaneous flap, which is otherwise called as tram flap. So, was there any pedicle formation or was there any pedicle in this procedure? I don't see any pedicle. I see that there was a tissue that has been removed and microvascular anastomosis was performed. So this is a free flap, right? So I can say it's not 19369. It is not going to be 19361 also because 19361 is coding for breast reconstruction with latissimus dorsi flap. And if you remember, during during the slide or when I explained this scenario or explained the CPT code 19361, I said that latissimus dorsi flap also have a pedicle, and in our scenario there was no pedicle, right? So 19361 is also incorrect between option A and option C. Option A is also incorrect because that is also coding for a single pedicled trans rectus, transverse rectus abdominis myocutaneous flap, which is tram flap. So this is also not a free flap. There is also a pedicle in 19367. And the correct answer is going to be option C, which is breast reconstruction with free flap. And your keyword is also the DIEP. So if you just focus on the keyword also, you would have got the correct answer. All right, so let me just look into chat. Okay, great answer. I can see a lot of great answer. Great job, Christina. Great job, Linda. Great job, Nazreen and Deborah as well. Excellent. Let's go and do the next exercise. Exercise number 3. Of the following answers, which code best describe the procedure? Option A, 19367, option B, 19368, option C, 19369, option D, 19367, and 19364. A patient undergoes a single pedicle tram flap breast reconstruction due to marginal circulation in the flap. The surgeon also performs a microvascular anastomosis of the inferior gastric vessels to the recipient vessel in the chest to augment the blood supply. What appropriate code is used, or of the following, which best describe the procedure? And there you go. Your timer has already begun to run. Coders, please your best answers. You all are doing a fabulous job so far. Okay, super job. I'm so proud of you. OMG, you all are so fast in placing the answers. Okay, so I will stop the timer Okay, so here we have a patient who underwent single pedicle tram flap breast reconstruction. Okay, so the keyword single pedicle tram flap. Okay, so that's your keyword here. And also patient underwent microvascular anastomosis of inferior gastric vessel. All right, so let's have a look into codes. 19369 is coding for a breast reconstruction with bipedical transverse rectus abdominis myocutaneous flap or tram flap. So this is a variation of the tram flap, and here you have two pedicles, right? But in our scenario, it was a single pedicle tram flap. There was no more than a single pedicle. There was no two pedicles or bipedicle flap. Sorry, tram flap. Okay, so that's why option C is incorrect. Next one, option D and option A, coding for 19367. This looks like a good code. Is for breast reconstruction with single pedicle tram flap. And scenario also said we had a single pedicle tram flap breast reconstruction. But why would I say option A and option D is incorrect? That's because I have to go and look at option B as well. B says that that's coding for breast reconstruction with a single pedicle tram flap requiring separate microvascular anastomosis or otherwise known as supercharging. So remember what I said in the previous slide. In 19368, there will be a single pedicle tram flap, and we will do a microsurgery. The surgeon will do a microsurgery in order to create an anastomosis, and he will connect some more blood vessels, and that procedure is known as supercharging. Okay, and that's what exactly happened here. Over here, the surgeon performed a microvascular anastomosis of the inferior gastric epigastric vessels. That makes option B the correct answer. All right, great job once again, Linda, Nasreen, Christina, and Debris. Excellent job. Okay, so I do have one more scenario to do. Okay, let's go ahead. Let's do that scenario as well. Here we go. Of the following answers, which code best describe the procedure? 19283, 19286, option B 19283, 19285, option C 19281, 19282, option D 19283 times 2. A radiologist places percutaneous localization device in the right breast using stereotatic guidance for the first lesion. A second and separate lesion in the same breast is then localized using during the same session, but using ultrasonic guidance instead, because it was not well seen stereotatically. Of the following answers, which code best describe the procedure? And coders, your time begins now. Okay, let's see which one is going to be the right answer here. Okay, please go ahead. If anyone is yet to place the answers, please go ahead and place the answer in the chat. Here we have a radiologist who placed percutaneous localization device in the right breast using a stereotatic guidance. And this was done for the first lesion, and then there was a second separate lesion on the same breast, and that was localized during the same session but using ultrasound guidance because it was not well seen using a stereotatic guidance, right? So, two lesions and two separate image guidance were used. And yes, I can see why you all have changed. Okay, I was about to give you some time or an opportunity to change the answers. Remember, yeah, we did go through this guideline previously as well during our hand pull scenario. So you must focus not on the laterality or not on the number of lesions here. Yeah, number of lesions definitely important to select the additional code, number of additional codes to be used or add-on codes to be used. But the primary code is selected based on, and the primary and the secondary code is mainly selected based on the guidance used. So if you have two separate guidance used, you will use two separate primary codes, right? That was guidance. So 19 option C 19281 19282 is incorrect. 19281 is using a mammographic guidance. We didn't have a mammographic guidance at all. Option 19283, it's a good code selection, placement of breast localization device, first lesion, including stereotatic guidance. That's good. But option D is incorrect because it uses two quantities of 19283. We had one stereotatic guidance used for placing localization device and the second localization device was placed using ultrasound guidance. So two different guidance were or two different modalities were used. So option D is incorrect. Between option A and option B, option A is coding for 19283 and 19286. That is for each placement of breast localization device. First lesion, including ultrasound guidance. No, it's for each additional lesion using ultrasound guidance. So this is an add-on code for 19285. If you see the parenthetical guideline as well, just below it, you can see it says that use over here use 19286 with 19285. So you can use 19286 only with 19285, right? And that also makes option a incorrect, and this is the guideline which I was referring to. If additional localization device placement without image guided biopsy are performed using different imaging modalities, report the primary another primary code for each additional localization device placement without image guided biopsy performed using same or using different image guidance modalities. So if different modality has been used, you can use different primary code, which makes option 19283 and 19285 the correct answer. Okay, I can see you all had a aha moment, and that was the entire purpose of this session. And let me know, Chorus, how did you do? And if you feel like you need more practice scenario, that's totally fine. You can always go and watch this playback in our AMCI channel. Go to our AMCI channel and you can locate the CPT Guideline Mastery playlist over here, and you will find all the previously recorded sessions, previously live sessions here. Okay, you can watch all the playbacks. All right, and we have a lot of contents over there. Imagine we almost covered the entire integumentary section topics. Yes. So, Goddess, have placed the survey link in the chat. Please don't forget to fill out that survey form. Let us know which topics you are looking forward to. And that helps us really to plan the content that's useful for you. So we will be back next Friday as well. And if you have any topics in your mind that which we haven't covered yet, you can let us know by filling that survey form as well. Your feedback is extremely important because not only when you share it with us, we are able to back with more sessions and the videos that are tailored for your needs. So please take a moment, just take a minute and let us know your thoughts. That's all we ask. Okay. As I said, don't forget to like, smash a like button, subscribe to our AMCI channel, share it with someone who really needs to see them. Okay. So we will be back next Friday with another topic. As I said, kindly let us know the topic as well in your feedback form, and we'll see for another session. So thank you, Miss Mills. Thank you, Miss Catherine. Thank you, team. Thank you, Curtis, for joining. We'll see you next week. Till then, stay safe and keep coding.
4,000 exam passers and free classes at AMCI. Learn to code straight from home or on the road at AMCI. We're on the East Coast, the West Coast. We're all around.